We are going to see about cerebellar ataxia. Cerebellar ataxia is a type of cerebral disorder caused by some form of damage to the cerebellum. Since the cerebellum is responsible for the planning and coordination of voluntary movements, we see a loss of muscle coordination resulting in upper and lower extremity dysfunction. We're going to see one case like we have CG is 4 years old girl who has been under medical attention since infancy for complaints of recurrent colds and delayed milestones. Approximately 2 months ago, she was brought to her local clinic for complaints of staggering gait and slurred speech lasting 10 days following the development of a viral fever that was treated immediately by their pediatrician. She has like past medical history, recurrent colds, mother, typical pregnancy and birth history. In investigation, they found like calcium deficiency. In general observation, healthy toddler with notable ataxic gait and difficult amputation on even surfaces. A range of motion within normal limits, bilateral upper and lower extremities, strength, global weakness, reflexes minimally exacerbated at corticeps, biceps, and Achilles tendons, balance, inconsistent protective reactions of arms, considerable difficulty with maintaining static positions, both in sitting and standing, required wide base of support and hand support to stabilize, requires close supervision at all the times for safety, as she cannot sit independently on the floor for play. And functional mobility requires wide base of support and hands on floor and minimal assist to get up from the floor to squat position. Ataxic aid, handheld guide for safety, but she doesn't like to be held while running, loses balance and trips easily. Perception and cognition, correctly names basic colors, can count to be 10. Affective, social, has some difficulty separation from parents, responds superficially to others. Occupational performance, self-care, require minimal assistance with dressing, moderate assistance with hygiene, grooming, and toileting. Play, decreased participation in lower extremity cross-motor play activities, impaired fine motor function, prehension patterns, and dexterity. Chooses to chooses toys, records, approximate cross motor skills. Speech, slurred speech. Assessment and plan. Diagnosis, cerebellar ataxia. Recommended interventions, steroid therapy, physiotherapy, and occupational therapy recommended. Patient's goals, physiotherapy, long-term goals, safe age appropriate, independent ambulation around the home. Occupational therapy, long-term goal, improve gross and fine motor coordination skills through activity and play groups.
Pathophysiology and an introduction to cerebellar disorders. The onset of cerebellar disorders is due to malfunction of the cerebellum, which is the highlighted orange area in the image on the right. This weakens the cerebellar motor pathways. When this occurs, we see the development of ataxic symptoms. Motor impairments that affect the planning and coordination of movement in all extremities are associated with cerebellar disorder pathology, as well as impairments in postural stance. There are many ways in which you can obtain cerebellar disorder. Each type will have a slightly different pathophysiology, as the cerebellum is a complex structure. Ataxia is a neurodegenerative syndrome, in this case, deterioration of the cerebellum causing dysfunction. Recent studies show that astrocytes, a type of glial cell, have a larger influence on the onset and progression of cerebellar ataxia than once thought. Numerous mechanisms of astrocytes' involvement in neurodegeneration are shared by diverse forms of ataxias and likely contribute to disease progression. The expression of mutant genes related to ataxia in astrocytes can cause developmental impairments of the cerebellum, ultimately contributing to degeneration. There are two important cells that will come up in the next section of pathophysiology that I'll explain here. First, we have Bergmann glia cells. These are a type of astrocyte within the cerebellum that are highly diversified. They're located in the cerebellar circuit and have a range of functions, including assistance and information processing. We also have Purkinje cells. These are large neurons that contain many dendrites. They play an important role in motor control and are in the cortex of the cerebellum. And this type of cell can be seen on your right in that image. It's also important to note that Bergmann glia cells are very closely connected to Purkinje cells, and Purkinje cells are already very vulnerable to dysfunction in individuals with ataxia. Gliosis is a primary immunoresponse that occurs at the onset of ataxia after injury to the brain. When Bergmann glia undergo gliosis, they can either positively or negatively alter the function of the Purkinje cells. At the beginning of the disease, Bergmann glia cells undergo gliosis, causing the Purkinje cells to become more helpful. They repair damage in the central nervous system by forming scars at the injury site, and they remove damaged or dead neurons. As cerebellar ataxia progresses, the Bergmann glia cells undergo gliosis again. And as mentioned before, the Purkinje cells are already vulnerable to dysfunction in individuals with cerebellar ataxia. So when the Bergmann glia cells undergo gliosis again, they actually cause the Purkinje cells to become more harmful this time by enhancing this dysfunction and in turn worsening disease symptoms.
Clinical features general to the condition: poor coordination, nystagmus or saccadic movements, dysphagia, dysarthria, and dysmetria, which is finger pointing, gait abnormalities, a wide base of support when ambulating, dyschronometria, which is distorted time perception, dyschiadochonesia, which means unable or difficulties to exert fast-paced movements or movements that require alternating movements to perform. Hypotonia, speech impairments, cognitive impairments, vision difficulties, and tremors, which worsen with voluntary movement. On the left side of the slide, there's a great mnemonic to remember the clinical features to cerebellar disease. I hope that helps everybody. The clinical features specific to this case study include global weakness, which was a 4 out of 5, delayed motor milestones in children, inconsistent reaction of arms, difficulty with maintaining static positions in both sitting and standing, requires a wide base of support, ataxic gait, loses balance and trips easily, difficulty ambulating on even surfaces, minimal exaggeration at quadriceps, bicep, and Achilles tendon, slurred speech, viral fever, and recurring colds. Activity limitations specific to the case study. Limited mobility will negatively impact the completion of ADLs, such as standing, walking, running, and sitting independently. Muscle weakness, delays in gross motor movements, unable to ambulate independently around her house, which will affect her ability to develop independence. Self-care is affected as she requires minimal assistance for self-care tasks, such as dressing, hygiene, grooming, and toileting. Participation restrictions specific to the case study. Ability to participate in lower extremity gross motor play activities is impaired. She is unable to sit up independently on the floor, which prevents her from being able to participate in floor play with her peers. Impaired fine motor skills will affect her ability to participate in class activities at school that involve writing. Unable to independently ambulate around the house will affect her ability to play, and reliance on her parents has caused her to respond superficially towards others, which will affect her social life, especially when she enters junior kindergarten.